Started. Hello, everyone, and welcome to today's ADAA webinar for mental health professionals, integrative behavioral therapy for body-focused repetitive behaviors. As I had mentioned, please feel free to introduce yourself in the chat and letting us know where you're joining us from. We're so happy to have you here today. And thank you to our presenters. I would like to quickly introduce myself. My name is Sasha Sicard, and I'm the Education and Membership Manager here. I'll be here to introduce you and to provide the Q&A at the end. Before we get started, I would like to go over a few items just so you know how to participate in today's webinar. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. If you'd like to receive the recording, please just email me. My email is right there, and I can provide you that link. For those who applied for CE/CME credit, you'll receive an email within 24 hours and instructions for completing your CE requirements. You have all joined today's webinar as a participant, and as such, you will be muted for the duration of the presentation. We've taken a screenshot of an example of the attendee interface here, and you should see something that looks like this on your own computer, desktop, or mobile device. You will have the opportunity to submit text questions at any time through the Q&A feature in your attendee interface. We will collect these and address them at the end during the Q&A session. I would now like to introduce our wonderful presenters, Drs. Marla Deibler and Renee Renardi. Dr. Deibler is a licensed clinical psychologist and the founder and executive director of the Center of Emotional Health of Greater Philadelphia, a multi-site behavioral healthcare center specializing in the evaluation and evidence-based treatment of anxiety disorders, obsessive-compulsive disorders, and related disorders, as well as neurodevelopment disorders. Dr. Deibler holds a doctorate in clinical psychology with a concentration in health and neuropsychology and a postdoctoral Master of Science in clinical psychopharmacology. Dr. Renee Renardi is a licensed psychologist and director of the Lakeside Center for Behavioral Change. Dr. Renardi specializes in the treatment of obsessive-compulsive disorder, body-focused repetitive disorders, and related conditions. She is the program developer of CourageCritters.com, an adorable skills-focused online system with a plush animal. Welcome, doctors. Thank you so much for joining us today. I'm going to hand off the screen to them and they will start the presentation.
Okay, wonderful. Thank you so much, Sasha. Hello, everybody. I'm sure there's some familiar faces out there. I wish I could see you. Hopefully some point we'll be able to see each other again. We are so excited, my friend and colleague, Dr. Deibler and I, to present this integrative behavioral therapy for body-focused repetitive behaviors. A little bit more about us on there. We're pretty easy to find. So if there's any questions beyond this presentation, let us know. We are going to cover a lot of information in the next about hour. So we're going to fly through it a bit and have some time at the end for Q&A. So just a little bit about our agenda today. Briefly in the beginning here, I'm going to talk a little bit about epidemiology and our need for effective treatment. We're going to go over some behavioral conceptualizations for BFRB, the current menu of evidence-based treatments, including HRT, COMB, ACT, and DBT. We'll go into each of those in a little bit more detail. We'll talk about the challenges to successful treatment, and Dr. Deibler will go into the rationale for the integrative behavioral therapy, or IBT, and also give you a really great example of what that might look like and what she has put together to integrate so many different components into currently a group treatment plan, but we'll go into a lot more detail about that. So first, just a little bit about the prevalence rates of BFRBs, and you guys can see this, but we do know, I'm gonna put my glasses on so I can see it, about 1.7% of community adults in samples report having compulsive hair pulling, trichotillomania. About 1 to 6% roughly report excoriation or skin picking. 20 to 30% of the population engages in nail biting to the point of it being a clinical issue. About 3% of the population engages in cheek biting, and just a little shy of 6% report mouth, lip, or cheek chewing behaviors. Now, it's interesting when we look at a much larger sample size of college students, about 59% reported subclinical BFRBs, and about 12% actually met criteria for a BFRB diagnoses. So it really kind of leans in the direction that these behaviors likely are quite common. Online study of, again, larger group of individuals, 23% reported probable BFRBs. So yes, there is a need for effective psychological treatment, and we'll go over that. Just because of the large percentage of the population that report clinical or subclinical levels of BFRBs, there's currently no FDA-approved medication. There is research, however, being done on pharmacological and precision medicine, but very much still in the early stages with these conditions. This is also a very heterogeneous group, which makes it a little difficult to research it as well. Not everybody is the same when it comes to these behaviors. Behavior therapies have been found to be the most effective treatments for BFRBs, and are based on these strong foundational theoretical concepts, which we'll go over in a little bit more detail today, and just a little bit about a 2020 meta-analysis, so you can take a look at that if you'd like. We're going to go over a lot of things today. So we do want to look at the biological influences, which do tend to set the stage for BFRB symptoms. We do know that there tends to be a genetic vulnerability for people with these behaviors. There's likely hormonal variables involved. The age of onset is often around puberty for a lot of people. It can occur at any age. We also look at sleep, nutrition, and exercise as likely biological influencers for how these behaviors may manifest, and also their heritability. We're going to talk a lot about a multifactorial self-reinforcement cycle for these BFRBs, and just really talking about a good old-fashioned behavioral analysis, right? So, really looking at what's the function of these behaviors. So the ABCs, what are the antecedents? And this can really include a wide range of internal or external experiences. Internal, of course, including things like thoughts, images, emotions, memories, sensations, and urges may serve as antecedents. External cues may be certain environments, certain activities, certain postures for how people may be sitting, right? So, and body movements in general. So we do want to take a look at those antecedents. Then we look at the behavior itself with the BFRB and the sequence in which that behavior occurs. So what happens first? Is there a search, for the target? So if somebody engages in skin picking, are they searching for it? What does the behavior itself look like when people are engaging in a BFRB? And then how do they dispose of the hair, skin, or nails afterwards? So before, during, and after we want to look at for the behavior. Then we take a look at the consequences. So, and to understand that there's both positive and negative consequences that occur, and behaviors that and consequences that occur both short term and long term. So we do want to build that into the assessment when you're meeting with individual clients. So to look at what are those short term consequences, it may be positively reinforced, and oftentimes is, by providing some sort of pleasurable feeling. For a lot of people with BFRBs, if they pull out that, ooh, this is a good one kind of hair, maybe it's got a real thick, root on it, maybe something they rub across their lips, they can get a feeling of satisfaction, a feeling of accomplishment. The behavior can be negatively reinforced by relieving an unpleasant urge or other unwanted internal experience. So maybe they're experiencing anxiety, maybe they're avoiding a situation, or maybe it serves self-soothing function for them. So we want to look at those short-term consequences. We want to look at the long-term consequences as well, which are oftentimes negative. So after a person engages in a BFRB, they may be like, oh no, look, now I have these sores on my face. I don't feel like I can leave. I feel so bad about myself. And because now we're emotionally dysregulated, that can actually keep the cycle going of BFRBs. We're going to talk more about that as well. Here's a little bit about the current menu of psychotherapeutic evidence-based treatments. The first being habit reversal training. And that can mean a few different things, but the components most often included in HRT are awareness training, competing response training, and stimulus control. Taking a look also at COMB, or the Comprehensive Behavioral Treatment by Charlie Mansueto, who many of you may know, and colleagues. Acceptance and commitment therapy and how that can be used, and DBT as an adjunct to HRT. Nancy Cuthin and her colleagues as well have done some great research. So we're going to cover a little bit more about each one of these treatments. So first, I'm just going to talk a little bit about habit reversal training. And we're going to fly through these, so I know you guys can read through it as well. So the goal here being to reverse that positive reinforcement of the behavior, doing psychoeducation, functional analysis, the awareness training, taking a look at the ABCs, introducing these competing responses, practicing and implementing incompatible replacement behaviors for the BFRB. So these are behaviors that when you do this, it makes it next to impossible to engage in the picking, pulling, or biting behavior. And also stimulus control, manipulation of the environment to avoid behavioral cues. Here, this next slide is a little bit about the research that's been done on HRT and the outcome data there. So you can take a look at this, and I won't go over all of the details, but what we find often with a lot of the research that we're going to present today is that we do get some early on results oftentimes, but those results don't tend to last, and people don't always respond in the way as much as we would like. So there's, like everything, there's strengths and limitations. So the strengths of HRT is that it's a simple behavioral procedure. So awareness enhancement can be often very helpful in decreasing these behaviors. The limitations is, like you'll find, a lot of small n's here. So it does make it very difficult to talk about generalizability of these studies. Results have not been replicated. There was an amazing study that came out in the beginning, but it has not been able to really be replicated. And it doesn't address all of these other components, which we think are typically involved with BFRBs, including the maladaptive cognitions, the emotions, the interpersonal factors, the sensory factors, and the avoidance behaviors so oftentimes found in folks experiencing these symptoms. Just a little bit about COMB. This was, I think, a really big step in BFRB treatments. And the goal here is to reduce the occurrence of these behaviors by interrupting that reinforcement cycle. Again, we start with a good assessment, a good functional analysis, looking at those ABCs, having clients to start with a self-monitoring process. And then what I really like about COMB is it's very nicely organized into an acronym called SCAMP, looking at sensory, cognitive, affective, motor and awareness, and place and environment domains, and looking at which category maybe you need to focus on a little bit more for that particular client. There's a great book too on this treatment published by Charlie and his colleagues. We want to identify and implement the CBT interventions that can be helpful within those target domains. And then it also includes a component of evaluating the effectiveness and modifying interventions as needed. There's been a little bit of research on this recently. So we do see some case studies showing some promise. An uncontrolled study that was done, again, pretty small n's here. And in some progress in some areas, maybe not as much in others. And then recently a randomized controlled trial, which the results are a little confusing as to how effective it is, with patients reporting some positive results, and then interviewers maybe not seeing those significant changes. But it's something that definitely deserves further consideration, further study. Strengths and limitations of this protocol as well. There's a lot of strengths to COMB. It's highly individualized, it's flexible, it's very well organized, including a really nice comprehensive functional analysis. There are a number of different strategies that can be used, especially compared to HRT, and it uses more traditional CBT interventions. The limitations, again, these randomized controlled trials, a little difficult to interpret at this point, very new in looking at this treatment, and again, small n's. There is greater potential for therapist non-adherence and between therapist variability, just because of the complexity and flexibility of the application of COMB. Now, again, COMB uses these traditional cognitive approaches, including cognitive therapy. And so it doesn't make use of some of the third wave evolution of CBT, which we'll talk a little bit about too. And with that, I will turn it over to my colleague, Dr. Deibler.
So acceptance and commitment therapy has also been used to treat BFRBs. And if you're not familiar with acceptance and commitment therapy has the goal of being able to be fully engaged and present in your every moment-to-moment experience, regardless of what is happening internally, whether you're having unpleasant internal thoughts or feelings or sensations, and still choosing to move toward what matters most to you in life, so that you can live a rich, meaningful life despite what may or may not be showing up on the inside. ACT is actually intended to be a process-oriented behavioral therapy, and it uses a lot of metaphor, and it operates on the premise that psychological suffering is the result of experiential avoidance, that avoidance of the unpleasant, unwanted private experiences that we all experience. And there are 6 main core processes within the ACT framework. Just to review them, if you aren't familiar with them, there's the present moment experience, which is essentially having contact with the present moment rather than reflecting on the past or projecting into the future. And it's a fluid, flexible process involving your 5 senses to be fully aware and engaged. There's acceptance, and acceptance is essentially practicing non-judgmental awareness of your private experiences, allowing them to ebb and flow, letting go of what isn't within our control. There's cognitive diffusion. Cognitive diffusion is when we are able to step back, get a little bit of distance from our internal experiences, looking at our thoughts rather than from our thoughts, noticing our thoughts rather than getting caught up in our thoughts. There's self as context. Self as context is essentially being able to take a flexible perspective from within us as well as without and outside of us. And then there are values. Values are essentially what matters most to us in our lives. They're the qualities that we want to bring to our life and everything that we do. And finally, committed action. Committed action is when we move toward our values in action, even if we're experiencing unpleasant private experiences in our minds or in our bodies. It's essentially values-oriented action. Now, there are also, like the other modalities, there are some studies on this, although there are really only a handful of studies on acceptance and commitment therapy for BFRBs. Overall, small studies of ACT-enhanced HRT have demonstrated some significant improvement immediately following treatment, but then there's that treatment drift of gains at follow-up. And there have also been a couple of studies of ACT alone demonstrating, again, significant improvement, but we see that drift of treatment gains post-treatment. So some really useful ways of approaching BFRBs, but still needs to be looked at further. In terms of the strengths of the protocol, there are definitely some strengths with acceptance and commitment therapy. It does some really unique things in practice. Firstly, it addresses experiential avoidance that are often associated with BFRBs. So that internal stuff, the unhelpful thoughts, the unpleasant emotions, the urges that people experience. It focuses on some important concepts that are generally neglected by the other models, such as the idea of psychological flexibility, focusing on willingness to experience all that internal stuff instead of trying to essentially reduce it or push it away. And so the idea of willingness, of acceptance, of being able to think flexibly and move around and still focus on what's important to you, regardless of whether or not you're picking or pulling, is the focus of ACT. And that's certainly a strength. But there are also limitations to this protocol. There are small n's, as you can see, which may not yield generalizability. Much more work needs to be done here to examine the utility of acceptance and commitment therapy in BFRBs. Also, ACT is a pretty complex treatment model. It does require some training, so that can become kind of wieldy if you haven't had the background in order to be able to implement ACT effectively. And also, ACT isn't intended to be manualized. It's really intended to be a process-oriented approach in which you're with the client moving around that hexaflex in moment-to-moment interactions. And so it's difficult really to study ACT as an intervention.
All right, I'm going to jump back in again, and I'm going to talk a little bit about dialectical behavioral therapy, which many of you I'm sure are familiar with. But again, great treatment approach, and we'll go into how we weave all of these things together with the integrative model. But the goal here with DBT is really being able to build emotional regulation skills to change these maladaptive patterns. And we know oftentimes people with BFRBs struggle with these types of things. So DBT oftentimes, it does include these 4 components: mindfulness training, being present in the moment; distress tolerance, being able to tolerate distress in difficult situations; emotional regulation, effectively managing these strong emotions; and interpersonal effectiveness, reducing interpersonal chaos by improving communication and assertiveness. Little bit about the outcome data with DBT enhanced HRT. So again, not very many studies, small n's, and again, we do tend to see that drift in gains with time. So at those 3-month and 6-month follow-ups. So there are definitely some important components that we can take from this too. In the randomized controlled trial, they're a little bigger in, which is nice. In initially seeing some improvements, but then as time goes, tending to see those improvements decrease. So strengths and limitations of the DBT protocol. Important things here, right? Strengths. It addresses the skills that we need to focus on emotional regulation, distress tolerance, and impulsivity. It's a little bit less abstract than other treatment models like ACT. Limitations here, again, those small n's. HRT and DBT protocol did not include interpersonal effectiveness, which is something that Dr. Deibler has included in the integrative model, which we're going to spend most of our time here discussing today. No randomized controlled trials of DBT as a standalone therapy. So just a little bit about the challenges to successful treatment. So again, we kind of flew through some of the research on the current menu, but here are some of the challenges that we can take away from that research, things that we know at this point. We do know that BFRBs tend to have a chronic course. So a lot of people are in it for the long haul here. We want to set realistic treatment expectations. We want to maintain motivation to be able to consistently utilize strategy, right? And hopefully that would reduce the drift, but these have been challenges. Looking at automatic versus focused nature of these behaviors, attentional abilities, set shifting, and psychological flexibility haven't been looked at as much as probably need to be. Increased sensory sensitivity, experiential avoidance, all of the emotions that tend to drive these behaviors, the impact of these behaviors on people's self-efficacy and self-worth, and feelings like shame and things along those lines that are often not addressed so far in many of these treatment approaches, the interpersonal impact of BFRBs, and the lack of dissemination of standard care are all challenges to successful treatment of these conditions. So Dr. Deibler is going to talk now about the integrative behavioral therapy, or IBT, approach for BFRBs.
Thank you, Dr. Renardi. So I'd like to share with you an integrative behavioral therapy for BFRBs. And this model is based on that shared underlying behavioral principles that underlie these other therapies. So this is not something entirely new. It's just providing a unified treatment protocol that utilizes the full range of these scientifically validated interventions in order to maximize and maintain treatment success. Because right now, what's happening in evidence-based treatment for BFRBs is people are using one strategy or another, and there just seems to be a whole lot of difficulty in maintaining treatment gains. And so the integrative behavioral therapy model integrates the essential components, the parts that people find most useful of COMB, of HRT, of ACT, and of DBT in order to present a current cohesive treatment plan for your patients, with the goal of improving someone's quality of life by changing the way that they relate to their BFRB experiences and to broaden the tools that they use to manage those symptoms more effectively. So like all behavioral models, integrative behavioral therapy for BFRBs is based on a good functional analysis. So just like Dr. Renardi showed you earlier with that little circle, we'll cover that again. This is essential to understanding what's going on with someone's individual symptoms because it's so heterogeneous, and being able to effectively intervene. We start by orienting treatment toward using ACT's psychological flexibility model. And the reason that we do this is that we want to put out at the very beginning that the goal here is to reduce experiential avoidance and increase values-based behavior. The goal is not to get rid of someone's BFRB. Now, their BFRB symptoms may decline and they may paradoxically disappear, and that would be wonderful if it does. But the goal here is to reduce their experiential avoidance so that they're able to live the kind of lives that they want to live. The framework that we use for the functional analysis and the organization of interventions that we use in this model utilizes the SCAMP framework from COMB. It's a really excellent way to conduct and organize a behavior analysis and be able to set up and organize treatment interventions. So it utilizes that in terms of organizational structure. And then moving through treatment within that SCAMP framework, we use elements of HRT, of traditional CBT, of acceptance and commitment therapy, and of DBT skills used within this framework in a very strategic manner to maximize therapeutic outcomes and target those under-addressed challenges of BFRBs that Dr. Renardi mentioned. So looking again at this multifactorial self-reinforcement cycle, this is what we really want to help people to understand at the outset of treatment and looking at the way in which their BFRB is reinforced. So again, there's that biological influence that sets the stage for whether or not an individual is going to manifest a body-focused repetitive behavior and how those symptoms will play out over time. Then there are antecedents. The antecedents, whether they are internal or external, serve as cues for the behavior. Those antecedents can be broken down into categories that is outlined in COMB, those SCAMP categories. So those antecedents may be sensations and urges, they may be cognitions, they may be affect and emotions, motor habits and levels of awareness, and place and environment, right? SCAMP. And we're going to be going through this as we talk about interventions and we outline treatment. Then that leads to the behavior. The behavior is carried out as a means of trying to self-regulate and avoid that unpleasant internal experience. And that's carried out in a particular sequence, as Dr. Renardi mentioned. Following the behavior, there are consequences. Consequences occur as a result of the behavior, and that serves to both positively and negatively reinforce that pattern. And so this is how the cycle continues. So at the outset of treatment, we want to utilize an ACT matrix in order to help people understand the psychological flexibility model through which we want people to be able to view their BFRB. And what this does is it helps people to understand that a BFRB is a means of self-regulation. It's a way for people to try to modulate their experience. And it helps to normalize the behavior. BFRBs can be so isolating, and people can feel as though this is so unusual. This really helps to sort of normalize this experience that a BFRB is really trying to tell you something. It's trying to tell you that there's some kind of internal unpleasant experience that you're trying to push away with these behaviors. And so it's important to normalize that experience and demonstrate that this is simply a maladaptive pattern that's been established that we can learn to reroute. This also fosters greater acceptance. It fosters greater willingness and openness to experience, right? Well, the goal again is not to push away the BFRB, to get rid of these symptoms. The goal is to allow these internal experiences to be there and get better at having these experiences so that one doesn't have to resort to trying to force them away, which isn't effective in the long run. It also orients people toward a focus on their values, who and what's important to them in their lives, to help them to understand that we want them to live a happy, meaningful life, whether or not they have a BFRB. We don't want them to be caught up in having a BFRB identity or in the control agenda, right? That trying to get rid of it. The goal is to try to look at what's going on the inside that is unpleasant and unwanted, and helping people to change the way that they relate to those experiences so that they're no longer pushing them away and they're dealing with them more effectively. And of course, there's a potential for paradoxical outcomes. When we learn to better regulate our internal experiences, behaviors that we use to avoid and push away those experiences tend to diminish. So for those of you who aren't familiar with the ACT matrix, I'd like to show you briefly the psychological flexibility model and how it's consistent with parts of other models we use to treat BFRBs. And we use this in treatment because we want patients to be able to understand this as well. So to orient you to this diagram, the bottom portion of the matrix includes private internal experiences, that which I wouldn't know unless I asked you, because they're inclusive of what happens in your mind and in your body. And then the top portion of this matrix includes external outside experiences, inclusive of that which I wouldn't know unless I asked you, or that which I wouldn't know unless I were watching you, like with a camera, for example. It's observable behavior. And then the center there is the ability for you to be able to make these internal and external observations. It's noticing the difference between the internal and the external. So let's begin in the right quadrant here. So the right quadrant here is what your values are, what matters most to you. What kind of person do you want to be? What characteristics you want to bring to the things that you do in everyday life, like who and what matters. And then we move toward the upper right quadrant here, and we ask people, how would I know that these things below are important to you if I was observing your behavior? So in other words, what are you doing in the service of what's important to you? And it's notable that some of these actions are not only ACT consistent, but they're also consistent with some of the behaviors that we might encourage in other approaches, such as in traditional CBT and behavioral activation, for example, or we might encourage in other things like in DBT skills, although they're not framed in the same way. In the lower left quadrant, we ask, what are those times that show up on the inside? In other words, those unpleasant, unwanted, uncomfortable internal sensations and internal experiences that show up in our minds and in our bodies. And it's worth noting that this is more diverse, but it is inclusive of the sensory, the cognitive, and those affective cues in the Comb model, and the urges and other antecedent cues that are identified and worked with in HRT. And then finally, as we move up to the upper left quadrant, we ask, what are the actions that you do to move away from or to push away these unwanted private experiences? And we can think of these things as including distraction strategies, as opting out and avoiding different kinds of avoidance behaviors, thinking strategies such as blaming, reasoning, and short-term soothers such as substance use, acting out behaviors, and behaviors such as picking, pulling, and biting that are meant to provide short-term relief from the unpleasant stuff that shows up on the inside. Now, these dots, they may be adaptive or they may be maladaptive, but regardless of judgment, these strategies often provide short-term relief of our times because the times inevitably reemerge and we get caught up and stuck in this cycle of engaging in away moves, which take us away from what's important to us and really bring that focus in on trying to force away the unpleasant stuff on the inside. And if you're familiar with DBT, you might recognize the biosocial theory here in this, which asserts that when people are biologically hardwired toward emotional vulnerability, they tend to have a relatively low threshold for responding to emotional stimuli. And in doing so, they wind up responding with intense emotional reactions, and then they have difficulty returning to a baseline level of emotional arousal. So they get caught up in these, essentially in these away moves. And in ACT language, we would say that when we get stuck in this cycle of experiential avoidance, we remain in distress and in our ineffective efforts to try to struggle with or force away these unwanted behaviors. And we find ourselves ineffective and far away from the people that we want to be in our daily actions. So a word about individualized treatment. What we're going to be sharing with you is set up as a group protocol, but you really could apply this to individuals as well. And in doing so, it can be individually tailored and it could be adapted for the individual. So if you're carrying this out as an individual therapy intervention, you could spend a different amount of times on the different domains that are relevant to each individual person, as you would discover in that functional analysis. And then for each SCAMP domain, it might look a little bit different. So what I'm going to show you could be applicable to a number of different people, which is why we use this as a group protocol. But really, you could spend more or less time on individual domains based on that one patient's needs. So if someone really struggled with maladaptive cognitions, for example, you could spend more time on cognitive diffusion. If someone had more difficulty with affect regulation, you might spend more time on emotion regulation skills, for example. So just a word about individualized treatment in using this model. But what I'm going to show you is the way in which we have applied this to a group. And in carrying out this as a group protocol, it's set up as 14 weekly individual sessions, and it uses symptom assessments to monitor progress and establish a baseline as well. There are monthly optional free support groups in conjunction with treatment so that individuals can process what they're experiencing and connect and reduce some of the isolation that is sometimes experienced in BFRBs. And individuals in those groups have the opportunity to share their experiences with other people and that's not only meaningful and validating, but also relieves a great deal of shame and negative beliefs about oneself as well. So in session 1, what we want to do is essentially begin with psychoeducation like we would in any of these treatment protocols. We want people to understand BFRBs, treatment for BFRBs, the rationale for using integrative behavioral therapy. And we want to then begin in homework assignment with helping people to begin to identify their values, begin to identify that stuff that shows up on the inside, and identify those away moves, those maladaptive strategies that people use to push away that internal stuff. So we give that as homework so that we can then utilize that information in the treatment next session. So the focus of session 2 is essentially building motivation. Maintaining motivation can be so difficult in BFRB treatment. So this is a really essential component that's not directly addressed in other treatment models. And we utilize that psychological flexibility model as a treatment orientation framework to build motivation by shifting the focus as I mentioned before, away from the expectation of extinguishing the behavior with treatment, in other words, experiential avoidance, which is a persistent challenge for those with BFRBs, toward living a meaningful life, even in the midst of discomfort. And by doing so, we guide individuals toward the desirable direction of swimming downstream. It's much simpler than that, which can often feel like futile efforts to swim against the current. Now, we also we illustrate and discuss the control agenda and talk about creative hopelessness. And we use metaphors, act metaphors, such as the tug of war with a monster, with which you might be familiar, or passengers on the bus. And we illustrate that continual struggle in which people are engaged and how people can have the freedom to move toward what's important to them when they're willing to experience the stuff that shows up on the inside and changing the way that they respond to their internal discomforts. So we explain that when most people struggle, they think that it's because they're not trying hard enough, essentially. But we ask them, what if the struggle itself is the problem? What if it's not the BFRB? So we ask patients then to be willing to try something different, to be open to changing their relationship with the private experiences instead of continuing to struggle with them. In terms of acceptance and talking about willingness versus willfulness, we help people to ask themselves, are we willing to have that which we've already got, essentially? Not because we want it, not because we like it, but in order to learn to sit with it and to experience the pain of it in the service of ending our suffering. And there's a paradox of acceptance in that we give up control of our thoughts, emotions, and bodily sensations, and we in turn gain control of our lives. We talk about setting intentions versus expectations, and I talked about this a little bit earlier, I alluded to this. We essentially help people to approach their BFRB with curiosity for observing it and to learn from it, to learn about the experience rather than trying to struggle with it and trying to make it stop. We set the intention of changing the relationship with the BFRB and the private experiences that drive and maintain it. And for homework, we start to teach them about mindfulness. We want them to read about mindfulness, and we want to reinforce some of these concepts by providing homework related to willingness. And we also have them start to track their BFRB behavior with a behavior log. In session 3, we engage in awareness training. So unlike other behavior protocols, we prioritize mindfulness practice. Not only does this address the problematic automaticity and the lack of behavioral awareness, which can be particularly challenging in BFRBs, but each in vivo mindfulness practice in each session focuses on an evidence-based benefit of mindfulness practice, targeting, for example, attentional skills, the ability to be an observer of one's experience without reactivity, acceptance of one's own thoughts, emotions, bodily sensations, and emotional well-being versus via self-compassion. And we continue to encourage these skills with homework practice every week. So we want people to really get into the practice of engaging in mindfulness. And we demonstrate that by beginning each session with a mindfulness practice. And we then begin the functional assessment using Combs SCAMP structure. So we want to take a look at that behavior log, and we want to start helping people to understand the sensory, the cognitive, the affective, the motor, the place breakdown of the way in which BFRBs are experienced. So we send them home with another behavior log and homework to work on mindfulness. Note that we don't sequence SCAMP in the same order as COMB. We begin not with the most relevant domain, but with the most approachable concrete domain, with interventions that are typically easiest to implement and that people tend to grab onto more easily. So this encourages momentum and an early sense of mastery and internal locus of control. So we use non-threatening stimulus, such as attention to an itch, for example, to encourage willingness to experience a sensation that's a little uncomfortable, with curiosity early in treatment, not bringing the BFRB sensations into it, but having them to experience a different kind of bodily sensation. And then later in treatment, once skills have been built, we're going to conduct urge surfing again to the urge or the sensation that precedes the BFRB itself for the person once they've gained some regulation skills. And we practice the skills with attention to the evidence that a significant number of individuals with BFRBs have sensory sensitivity, thus learning to be curious about and open to the rising and falling of bodily sensations without reactivity to those sensations. It addresses something really important here that isn't addressed in other treatment models. In session 5, we focus on awareness training and the motor habits and environmental factors domain. So we look at stimulus control strategies. We teach them that stimulus control strategies can be utilized as a way to manipulate the environment so that we decrease the presence and the intensity of BFRB cues. And we teach them contingency management strategies, such as a token economy, to set up reward systems and positive reinforcement for the practice of homework and for the implementation of strategies. So we really want to emphasize here awareness training of stimulus control, of setting up good contingency management for an individual, because it's not easy to implement these strategies during the course of the week between sessions. And we want to make sure that they're setting themselves up for success. So sessions 6 and 7 address the cognitive domain, with session 6 focusing on curiously observing the mind's narrative without judgment, using ACT metaphors to understand the normal, protective, yet sometimes unhelpful function that our highly judgmental and analytical minds engage in. Self as context is also explored through perspective-taking exercises, and cognitive diffusion skills are taught to get distance from evocative thoughts so that individuals look at their thoughts rather than from their thoughts getting caught up in those thoughts. So that's session 6. And in session 7, we shift toward more classic cognitive distortions. We want people to see the errors in their thinking, but rather than restructure those thoughts in cognitive restructuring, we want them to see that these, although sometimes unhelpful thoughts are experienced, individuals don't need to get caught up in them and the emotions that are associated with them and that drive them toward these unhealthy behaviors. So we want them to acknowledge them, to be able to identify them as unhelpful and perhaps distorted, but to use their diffusion skills to get some distance from them. It simply is not worthy of attention. And so individuals learn to observe distortions for what they are and the unhealthy direction that they're likely to lead, and instead choose to diffuse from them and turn toward values-based actions instead. And then for homework, what we want them to do is to practice these skills by implementing these exercises and implementing some of these strategies, monitoring how effective they are. And each week we check in with them to see what kinds of strategies they tried, how helpful they feel they were, and make sure that we have discussions about what's been useful, what hasn't been useful, and how to increase the utility of the strategies that they implement. In session 8, we shift toward emotional processes. So session 8 begins to address the affective domain and uniquely targets the experience of shame. The whole session is about shame and other difficult emotions through a focus on embracing these emotions with kindness and self-compassion for one's experience. The emotional sequelae of struggling with a BFRB can really be very significant, and it's vital to address this adequately in order to help individuals heal and move forward. In the past, before doing this kind of integrational behavioral therapy, one of the things that I did from the very beginning of my practice was to have a free support group, because it felt like in order to make use of any of these evidence-based treatments, people really need to push past their rejection of themselves, essentially, to be able to treat themselves with kindness just as they would someone else who's struggling. And so session 8 focuses on self-compassion. We want individuals to be able to learn the essential components of effective self-compassion and be able to practice this expression of kindness and support for oneself through experiential and written exercises. So that's what we do to help people to develop this skill set. And we send them home with reinforcing exercises as well so that they can practice. Sessions 9 through 12 focus on the affective domain as well, as emotional reactivity and dysregulation are significant drivers of BFRBs, and it often remains challenging for individuals to self-regulate in adaptive ways, even following these other evidence-based treatments. And so session 9 introduces the concept of states of mind from the practice of DBT, learning to tune into the wise mind as well as other emotion regulation skills from DBT, which aim to teach the identification and understanding of emotions, decrease emotional vulnerability and suffering, and increase positive emotions, which continued to then to be developed in session 10. Some other things contained in session 9 are things like understanding opposite action, understanding problem-solving skills, for example, and we send them home with reinforcing behavior therapy homework, helping people to practice these skills. So session 10 then continues to explore some of these skills and helps them to practice these in session and also as homework. Session 11 shifts to improving interpersonal effectiveness. So this is an important area of skills development that is neglected by all of the other BFRB protocols, that includes, including that DBT plus HRT protocol studied, as Dr. Renee had mentioned. Now, interpersonal effectiveness is one of those 4 modules of DBT, and it's particularly important to develop this skill set for people with BFRBs, as so many report interpersonal struggles, either as a result of their BFRB or that it precedes as an antecedent the BFRB. So this session focuses on attending to the relationship in healthy ways rather than avoiding them, learning assertiveness skills, balancing priorities versus demands regarding the social world, balancing one's own needs versus a sense of obligation to others, and building a sense of interpersonal mastery and self-respect. And session 12 targets distress tolerance skills, utilizing interventions from ACT and DBT to focus on, again, turning toward difficult emotions and learning to make space for them, learning to sit with them more effectively, rather than avoiding these experiences and trying to push them away with unhealthy coping behaviors. We want people to build those distress tolerance skills, to be able to experience the hard times and watch them naturally pass as they do. And then in our final sessions of therapy, we focus on relapse prevention, and we return to the orientation toward meaningful living. So in session 13, we review the homework, we look at what we've done, we identify and plan for potential future antecedents because it could come up again. And we engage in vivo exposure and response prevention, beginning with urge surfing to a BFRB and then to an individual's antecedent cues. And we wrap up treatment in session 14 with the continuation of relapse prevention planning, troubleshooting any kind of potential areas of need, and completing the treatment by turning back toward the individual values and focusing on how one wants to really ideally live their life with the ACT 100th birthday party exercise, to help people see that there are many things that are much more important to them in their lives that they want to turn their attention toward, as opposed to their picking or pulling behavior. So we also encourage, following treatment, continued participation in monthly support groups for maintenance, as well as booster sessions as needed should the need arise. So as you can see, these are those challenges to BFRB treatment, these under-addressed areas, and we've really attempted to target each of these areas through this integrative behavioral means of putting together a really cohesive, comprehensive intervention that is really tied to behavior therapy and everything we know to foundationally be effective for changing difficult behavior patterns. This is our contact information. Should you wish to reach out, please feel free to send us an email, give us a call. We're happy to answer any questions. We hope to be providing more training in the future on these things. We hope to be able to provide folks some publications and some other written works to help demonstrate some of these interventions and how this can be utilized in your practice or to help yourself. And we thank you for giving us your time today. We're happy to take questions.
Thank you so much, doctors. We have some great questions and responses in our chat right now. We'll start off with kind of an easy one. Do you guys have any reading materials that you would suggest for someone who's working on implementing this?
Yeah, I recommend the book that I mentioned earlier. I don't know if you have it on you or not, Dr. Deibler, but Charlie Mansueto's book. So it's if you look up comprehensive behavioral model and type in his last name, Mansueto, that's a great, Combe gives a really nice outline to these things. And if you look at, just looking up some of the research on HRT and DBT and ACT and how it's been utilized in treating BFRBs, you will find some articles as well. There's not too many of them. So as sad as that is, they're relatively easy to find. A website that I would also encourage people to check out is the TLC Foundation for Body Focused Repetitive Behaviors. And their website is BFRB.org. And there's links there as well to articles and webinars and other resources.
We hope to be able to provide written materials at some point that will be available to everyone.
Great. Well, we'll keep an eye out for those when they do show up. So we do have a question on how long each of the sessions are for your treatment plan.
60-minute sessions is kind of the sweet spot. 45 minutes is a little bit too short. There's just so much material to cover that an hour seems just about right.
Great, thank you.
And every session too starts with a 5-minute mindfulness practice, which is so nice. It's such a good way to orient people to, just to clear some of the stuff that they've carried throughout the day to really help them shift gears to focus on all the material that's covered during that hour.
Thank you. Okay, we have some longer questions coming in, so let me read those. So we had one that goes, how is acceptance of the BFRB consistent with the value or goal of promoting healthy skin? Can acceptance be misconstrued as passivity? So do you mean accepting the private experience and not the picking behavior?
Yeah, so acceptance in the framework of acceptance and commitment therapy means acceptance of your experience, to be, fully present and engaged in what's happening and willing to experience everything that you're experiencing through your senses. So, if you're having a bad day, for example, and you're experiencing those antecedents, it's to allow yourself to have those experiences and respond by turning toward what's important to you rather than trying to push away those negative thoughts or trying to get rid of anxiety or trying to get rid of some negative emotion or trying to get rid of the urge. Instead of getting caught up in that struggle, to allow yourself, to give yourself the space for experiencing that internal stuff, because everybody does experience yucky stuff, right? Everybody experiences unwanted thoughts from time to time and unpleasant emotions from time to time, right? It's just part of our common humanity. So acceptance means allowing yourself to be willing to experience all of that stuff that we all experience instead of getting caught up in struggling to push that stuff away.
Yeah. Thank you so much. And we'll take one final question today. And then if we do have, there are a few questions we didn't get to, but you're always open to email webinars at ADAA.org. And I can send those over to the doctors and kind of in a more organized fashion. So our last question today will be, how flexible is the order of the protocol you are proposing?
Yeah, it can be flexible. I organized it in this manner because I think it's important to start off with some really good foundational work on motivation and setting up the goal of therapy to make sure that people understand that the goal is to be able to experience all the internal stuff, whether or not that is unpleasant, and still turn toward what's important to you. But in terms of the interventions, although I think that, setting that foundation through conducting an ACT matrix, I think is important. But when it comes to addressing, the sensory stuff or the cognitive stuff or the affective stuff, I think that could certainly be reorganized in a way that makes sense for an individual patient. The reason that I set it up this way was that I think the sensory tools are the ones that are easiest to understand and to implement, and people like to explore the fidgets and the other things, and I think it's easy to understand and put into place, so people feel motivated because that's easy to do. And that stimulus control stuff, the environmental manipulation, those are also pretty easy to implement. So I think it's important to give people momentum in the beginning. And the cognitive stuff and the affective stuff, I saved that for the end because really those are the hardest things, right, in therapy to help people to change. And so that's why I saved them for last. I think it's important to really spend some time processing that stuff, practicing those skills. Those are not things that are easy to implement as opposed to, keeping some fidgets around when you're sitting in front of the TV if you tend to pull while you watch TV, for example. So that's why I set it up that way, but I certainly think that you could reorganize it if that makes sense for an individual patient.
Yeah, thank you so much. I would just like to take a moment now to highlight ADAA's upcoming annual conference. It will happen in March in Denver, and we're looking forward to seeing everyone in person. We have a great series of sessions lined up that we are currently finalizing, so we hope to see everyone there. And we also hope that if you are not yet an ADAA member, that you explore our wonderful membership benefits, including year-long access to continuing education webinars, such as this wonderful one we're at today. We have our special interest groups, which include peer consultation groups, access to our online journal, clinical trials, and much, much more. If you have any questions, please email membership@adaa.org. And I'd like to thank Drs. Deibler and Dr. Renardi for joining us today. I'd like to thank our audience for attending and all your thoughtful questions. Just as a quick reminder, if you have signed up for CEs, you should get an email from me. My email is right there. And if you have any questions or concerns, please feel free to reach out, and we look forward to seeing you in Denver or at our next webinar. Doctors, thank you so much for joining us today, and thank you for your time. I hope everyone has the best day. And happy holidays. All right, thank you so much.
Thank you.